In the world of acute cardiovascular medicine, few scenarios demand faster thinking, sharper clinical acumen, and more precise pharmacotherapy than acute coronary syndrome, or ACS. Whether you are prepping for board certification, rounding in the cardiac care unit, or working in the emergency department, understanding the intricate pharmacotherapeutic nuances of ACS can literally mean the difference between saving myocardium or facing irreversible necrosis. Today, we are diving into a comprehensive masterclass on acute coronary syndrome based on the latest guidelines and clinical updates from the American College of Clinical Pharmacy. We will cover everything: how to differentiate unstable angina, non-STEMI, and STEMI, the classic MONA initial therapies, the deep pharmacokinetics of oral P2Y12 inhibitors, the role of intravenous anticoagulants and glycoprotein inhibitors, reperfusion protocols, and long-term secondary prevention strategies. Grab your notebook because we are going through the complete management spectrum from first medical contact to long-term post-discharge survival. We break down our first clinical definitions. If you want to stay completely up to date with latest clinical guidelines and master advanced pharmacotherapy, make sure to hit that subscribe button and turn on all notifications. We have a massive wave of updated medical breakdown videos dropping over the next few weeks that you definitely won't want to miss. Let's dive in. To effectively treat ACS, we must first accurately define it. ACS is an umbrella term representing a spectrum of clinical conditions, ranging from unstable angina to full-thickness myocardial infarction. Let's break down the clinical classification based on subjective and objective findings, as outlined by the ACCP cardiac core principles. First, we have unstable angina. In this case, the patient typically presents with ischemic symptoms, such as crushing substernal chest pain or pressure occurring at rest or in an accelerating crescendo pattern. On the electrodiagram or ECG, you may observe ST segment depression, T-wave inversion, or transient ST segment elevation. Crucially, cardiac biomarkers like troponin remain negative, and there is none or minimal myocardial necrosis involved. Now let's move to non-ST segment elevation myocardial infarction, or non-STEMI. The clinical ischemic symptoms match those of unstable angina, and the ECG demonstrates ST segment depression or T-wave inversion. However, unlike unstable angina, cardiac biomarkers like troponin are positive, confirming cell death, and the injury is subendocardial, meaning it is a partial thickness myocardial infarction. Finally, we have ST segment elevation myocardial infarction, or STEMI. Patients exhibit severe, continuous ischemic symptoms, and the ECG clearly shows persistent ST segment elevation, or a new left bundle branch block, or LBBB. Cardiac biomarkers are highly positive. This represents a transmural injury, meaning a full-thickness necrosis of the myocardial wall caused by totally coronary occlusion. Before we jump into the specific medications, we have to look closely at the mechanical and biological chaos happening inside the coronary vessel. When we discuss a traditional type 1 myocardial infarction, we are tracking a highly predictable three-step pathological chain reaction known as the Prothrombotic Cascade. It all begins with plaque rupture. Over decades, an atherogenic plaque builds up within the endothelial lining of the coronary artery. The real danger isn't just the size of the plaque, but its stability. A type 1 myocardial infarction is triggered by the mechanical failure or structural fissure of these plaques' fibrous cap. The moment that cap ruptures, it exposes the bloodstream to highly prothrombotic substances hidden within the core, most notably collagen and tissue factor. The vessel suddenly views its own plaque as an open, bleeding wound. This exposure immediately triggers step 2, platelet activation. Under normal conditions, platelets float passively through the lumen. But the second they detect tissue factor and collagen, they undergo a rapid morphological transformation. They change from smooth discs into highly reactive spiked structures. They release structural granules packed with ADP and thromboxane A2, recruiting more platelets to the area. This creates a compounding wave of rapid platelet activation and aggregation directly at the rupture site, building a microscopic cellular plug. This leads us to the final critical step, thrombus formation. The activation of platelets runs parallel to the coagulation cascade, ultimately generating thrombin, which converts soluble fibrinogen into an insoluble mesh of fibrin strands. This sticky fibrin web acts like a net, trapping passing red blood cells and platelets, rapidly expanding the cellular plug into a mature, stable thrombus. Depending on the severity, this thrombus leads to either a partial occlusion, which we see clinically as unstable angina or non-STEMI, or a total occlusion, which presents as a catastrophic STEMI. By blocking the lumen, myocardial blood flow is cut off entirely, and the downstream heart muscle begins to die. Looking at this cascade, it becomes blindingly obvious why our pharmacological choices are so aggressive. Every single drug we pull from the cardiac cart is specifically engineered to target a precise fuse in this exact explosion. We use antiplatelets like aspirin and B2Y12 inhibitors to halt step 2, platelet activation, and we use anticoagulants like heparin or enoxaparin to put the brakes on step 3, thrombus formation. Optimal inhibition of thrombosis is the absolute paramount objective of all ACS management. Now that we know exactly what the enemy looks like under the microscope, let's break down the exact pharmacotherapeutic regimens we use to shatter this cascade. Now let's move to immediate management, or the MONA regimen. When a patient presents with suspected or confirmed ACS, immediate action is essential. The cornerstone of initial medical management relies on anti-ischemic and analgesic therapies, often remembered via the classic acronym MONA or MONA. M for morphine, O oxygen, N nitroglycerin, and A for aspirin. But while this acronym is familiar, the precise guidelines surrounding each drug contain nuances you must master. Let's begin with morphine, which provides crucial analgesia and decreases pain-induced sympathetic or adrenergic tone. It also induces vasodilation, providing a beneficial reduction in both cardiac preload and afterload. We can administer it by 2 to 4 mg intravenously, IV, every 5 to 15 minutes if symptoms are not relieved despite maximally tolerated anti-ischemic medications. Morphine holds a controversial place in contemporary therapy. At least 2 large trials have identified an association between morphine administration and an increased risk of death. Furthermore, morphine slows the absorption of oral P2Y12 inhibitor therapy, which delays their time to peak antiplatelet activity. Extreme caution must be used in patients with an inferior or right ventricular infarction. Let's move to oxygen. In ACS, supplemental oxygen helps attenuate anginal pain occurring secondary to tissue hypoxia. It should be considered if the patient's oxygen saturation drops below 90%, if they exhibit signs of respiratory distress, or if they have high-risk features of hypoxemia. Excessive supplemental oxygen given to patients without hypoxia can be harmful and is associated with increased clinical morbidity and mortality. Nitroglycerin facilitates direct coronary vasodilation and is highly effective in relieving acute chest pain or severe cardiogenic pulmonary edema by increasing venous capacitance. Give a sublingual tablet or spray at a dose of 0.3 to 0.4 mg every 5 minutes for up to 3 total doses. If pain persists after the very first dose, patients should go to the emergency. For persistent pain, heart failure, or severe hypertension, an IV infusion can be initiated within the first 48 hours at 10 microgram per minute and titrated up to maximum of 200 microgram per minute. Don't use it if systolic blood pressure is below 90 mmHg, if the heart rate is under 50, or if there is a tachycardia over 100 in the absence of heart failure. It's strictly contraindicated if the patient has taken sildenafil or vardenafil within the past 24 hours, or tadalafil within the past 48 hours. Avoid entirely in right ventricular infarction. Finally, we have aspirin, which inhibits platelet activation and stands as the single initial therapy proven to directly reduce mortality. All patients must chew and swallow a non-enteric coated aspirin dose of 162 to 325 mg as early as possible before any percutaneous coronary intervention or PCI. Following the procedure, a maintenance dose of 81 mg daily is strongly preferred over the higher doses to maximize antiplatelet activity while minimizing bleeding risks. Once initial MONA stabilization is underway and your 12-lead ECG is interpreted, the clinical road splits completely. You cannot treat a STEMI the same way you treat an non-STEMI or unstable angina. Let's break down these two distinct, highly detailed management pathways side by side, starting with the absolute medical emergency STEMI. In a STEMI, the coronary artery is completely occluded by a thrombose. Downstream myocardium is dying by the minute. Therefore, the absolute primary goal is immediate mechanical or chemical reperfusion. The gold standard treatment is primary percutaneous coronary intervention, or PCI. If the patient is at a PCI-capable facility, our goal is a door-to-balloon time of equal or less than 90 minutes. If the patient arrives at a non-PCI-capable facility but can be transferred to one quickly, the maximum acceptable timeline from first medical contact to balloon inflation is 2 hours. If a primary PCI cannot be achieved within 2 hours of first medical contact, you must immediately pivot to chemical thrombolysis using fibrin-specific agents like tinctiplase, alteplase, or retiplase. The quality metric here is a door-to-needle time of equal or less than 30 minutes. To keep that vessel open during or after reperfusion, you must initiate dual antiplatelet therapy, or DAPT, and systemic anticoagulation immediately. Although we will talk later in details about oral B2Y12 inhibitors, but here we should mention the strategy of B2Y12 selection. So for patients going for primary PCI, the guidelines strongly prefer the potent agents Prasugrel 60 mg loading dose or Ticagrelor 180 mg loading dose over Clopidogrel because they achieve faster and more intense platelet inhibition. If the patient is undergoing fibrinolysis, Clopidogrel is the mandatory choice. 300 mg as loading dose for patients 75 years old or younger, or 75 mg loading dose with no bolus if the patient is older than 75 years old, to minimize catastrophic bleeding risk associated with thrombolysis. Also, if the patient undergoing PCI unfractionated heparin or UFH is the standard choice, dosed as a 70 to 100 units per kilogram IV bolus if no GB2B3A inhibitor is used. If a patient undergoing fibrinolysis, systemic anticoagulation must be maintained for at least 48 hours and up to 8 days. Options include IV UFH or enoxaparin, dosed as a 30 mg IV bolus followed by 1 mg per kilogram subcutaneous every 12 hours in patients younger than 75 years old. Now, let's look at non-STEMI and unstable angina. In these scenarios, the vessel is only partially or intermittently occluded. But here we have a critical clinical rule. Fibrinolytic therapy is strictly contraindicated and harmful in non-STEMI and unstable angina because the clot is non-occlusive. The bleeding risks of thrombolysis vastly outweigh any benefit. Instead of rushing every patient to an immediate emergency open vessel procedure within minutes, management relies on risk stratification to choose between an invasive strategy going to the cath lab within 24 to 72 hours or an ischemic guided strategy, which is medical management with non-invasive stress testing later. So to decide how fast a non-STEMI or unstable angina patient needs to go to the cath lab, clinicians utilize validated risk scores. The first one is TIMI risk score, which consists of 7 variables, including age, more or equal 65 years, and presence of 3 or more coronary artery disease risk factors, plus prior stenosis more than or equal 50%, plus ST segment changes, severe angina, aspirin use in the last 7 days, and elevated biomarkers. A score equals or more than 3 indicates intermediate to high risk, favoring an early invasive strategy. And another risk score is GRACE, which calculates in hospital and 6 months mortality based on continuous clinical variables like heart rate, systolic blood pressure, serum creatinine, and Caleb class. A GRACE score more than 140 dictates an urgent invasive strategy within 24 hours. Now let's talking about antithrombotic regimen for non-STEMI and unstable angina. For oral B2Y12 inhibitors, Ticagrelor 180 mg loading or Clopidogrel 600 mg loading can be initiated upstream in the emergency department as soon as the diagnosis is made. Prasugrel shouldn't be given upstream in non-STEMI or unstable angina. It must only be given after the coronary anatomy is done in the cath lab, as it carries a high bleeding risk if the patient turns out to need urgent coronary artery bypass graft surgery. Anticoagulation is started immediately for all non-STEMI, unstable angina patients and continued for the duration of the hospitalization or until PCI is performed. Enoxaparin 1 mg to each kilogram subcutaneous every 12 hours. If creatinine clearance less than 30 ml per minute, adjust dose to 1 mg to each kilogram subcutaneous once daily. Fondaparinux 2.5 mg subcutaneous daily. This has the lowest bleeding risk but requires an extra dose of unfractionated heparin in the cath lab to prevent catheter thrombosis. Contraindicated if creatinine clearance less than 30 ml per minute. Unfractionated heparin 60 units to each kilogram, IV bolus, maximum 4,000 units, followed by a 12 units to each kilogram each hour infusion, maximum 1,000 units each hour, titrated to an APTT of 50 to 70 seconds. Navigating these pathways requires staying ahead of constantly moving goalposts. That is exactly why you need to stay tuned to the channel. We have a breakdown dropping very soon, covering the absolute latest guideline transitions, cutting-edge trial data, and the clinical updates you need to know for your practice and board reviews. If you haven't already, hit that notification bell so you don't miss those upcoming guideline masterclasses. Dual antiplatelet therapy or DAPT combines aspirin with an oral B2Y12 inhibitor, regardless of whether your patient followed the STEMI or non-STEMI pathway. Picking the right B2Y12 inhibitor requires looking at their pharmacology under the microscope. By comparing Clopidogrel, Prasugrel, and Ticagrelor, we can find that Prasugrel and Ticagrelor are much potent than Clopidogrel, while only Ticagrelor is active drug, not a prodrug. While Prasugrel is strictly contraindicated in patients with a history of stroke or TIA, and caution if the patient is older than 75 years old. For Clopidogrel, we can use it for patients who are poor metabolizers according to CYP2C19 because it's a prodrug and needs CYP2C19 to be activated. I know mapping out prodrug activations, CYP pathways, and reversible receptor binding can feel like a lot to process all at once. If you want to master these foundational concepts without the stress, make sure to check out our Simplified Pharmacology series right here on the channel. It breaks down complex drug mechanisms, receptor interactions, and pharmacokinetics into clear, high-yield, easy-to-digest animation that will make your next pharmacology exam a breeze. Moving deeper into the acute setting, let's explore intravenous options. Glycoprotein 2B3A inhibitors like double bolus, eptifibatide, or high-dose bolus, tirofiban, block the final common pathway of platelet aggregation, the binding of fibrinogen to the GP2B3A receptor. Today, their role is primarily reserved for bailout therapy during a PCI when a clinician encounters high-risk features such as a large residual thrombose burden, slow flow phenomenon, or instances where a patient didn't receive adequate pre-treatment with oral B2Y12 inhibitors. Routine upstream administration before PCI is no longer recommended. Alternatively, we now have Cangrelor, an intravenous, ultra-short-acting, reversible B2Y12 inhibitor. Cangrelor has an immediate onset and a half-life of mere minutes. It's indicated for patients undergoing PCI who have not been pre-treated with an oral B2Y12 inhibitor or those who cannot absorb oral medications, providing clean antiplatelet coverage that turns off rapidly if emergency surgery is required. Now let's answer a common clinical question. How long should a patient remain on dual antiplatelet therapy? Standard guidelines traditionally recommended a 12-month course of DAPT following ACS. However, contemporary management has become highly individualized. Recent data support that a shorter course of DAPT, 1 to 3 months, followed by B2Y12 inhibitor monotherapy, can successfully reduce bleeding events with equivalent rates of ischemic events in patients with high bleeding risks. Conversely, what if your patient is a very high ischemic risk but low bleeding risk? Continuing DAPT beyond 12 months may be reasonable. To make this objective, we utilize the DAPT score. For patients who score a 2 or greater, a prolonged DAPT regimen beyond 1 year is reasonable, as it significantly reduces ischemic endpoints and stent thrombosis. However, be aware that extended DAPT will increase bleeding events and doesn't reduce total mortality. Let's look at a major clinical challenge: managing a patient with underlying atrial fibrillation who just experienced an ACS event and received a coronary stent. This forces us to balance two competing forces: preventing a stroke from atrial fibrillation using systemic anticoagulants while preventing stent thrombosis using dual antiplatelets. Historically, these patients were kept on triple therapy: an oral anticoagulant, aspirin, and a B2Y12 inhibitor. However, clinical data has completely shifted this paradigm because triple therapy massively spikes life-threatening bleeding risks without offering a matching ischemic benefit. According to the latest guidelines highlighted in this protocol, double therapy is now the standard default strategy for the vast majority of patients. Let's look at the timeline breakdown. Triple therapy is now restricted strictly to the acute peri-procedural window, typically up to 1 week or until hospital discharge. Only in extreme scenarios where a patient's ischemic or stent thrombosis risk is exceptionally high should you consider extending triple therapy, and even then it's capped at a maximum of 1 month. After that brief initial window, aspirin is completely discontinued. The patient transitions directly into double therapy, combining an oral anticoagulant with a single B2Y12 inhibitor. This regimen is maintained for a default duration of 12 months. When it comes to drug selection, within this combination, the guidelines are explicit. DWACs are highly preferred over warfarin due to a vastly superior safety profile regarding intracranial hemorrhage. Furthermore, Clopidogrel is the antiplatelet of choice. The more potent agents, Prasugrel and Ticagrelor, should generally be avoided in double or triple therapy combinations unless the ischemic risk is absolutely overwhelming. as they exponentially increase major bleeding. Finally, once the patient successfully reaches the 12-month mark post-PCI, the antiplatelet is safely dropped entirely, and the patient steps down to long-term oral anticoagulant monotherapy. So, remember this core principle for your clinical practice. Drop the aspirin early, rely on DWAX over warfarin, and use Clopidogrel as your default antiplatelet partner. Minimizing the duration of triple therapy is the single most effective intervention we have to protect our patients from catastrophic bleeding while keeping their stent patent and their brain protected from stroke. Our job isn't finished when the acute clot is resolved. Long-term survival depends on aggressive secondary prevention to prevent major adverse cardiovascular events. All post-ACS patients should be optimized on 5 core classes of drug before discharge. The first one is aspirin, 81 mg daily. Second, B2Y12 inhibitors. Duration tailored by bleeding ischemic risk, typically 12 months. Beta blockers like metoprolol succinate and carvedilol indicated for all patients with an left ventricle ejection fraction smaller than or equals 40% and reasonable for at least 3 years in patients with normal ejection fraction to reduce myocardial workload. AC inhibitors or ARBs strongly indicated if the patient has an left ventricle ejection fraction equals or less than 40%, hypertension, chronic kidney disease, or diabetes. High-intensity statins like atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg indicated for all patients post-ACS regardless of baseline lipid panel numbers. Let's focus heavily on lipid optimization. All post-ACS patients are considered very high risk for future cardiovascular events. Under contemporary clinical lipid guidelines, a high-intensity statin alone is often not enough. If a patient fails to drop their LDL-C below strict target threshold of less than 55 mg per deciliter and a 50% reduction from baseline, non-statin therapies must be added sequentially. First, introduce ezetimibe 10 mg daily, which blocks cholesterol absorption at the brush border. If the LDL cholesterol still remains above 55 mg per deciliter, added a PCSK9 inhibitor, such as evolocumab or alirocumab. PCSK9 monoclonal antibodies prevent the degradation of LDL receptors, maximizing the clearance of circulating LDL because the risk of recurrent events peak within the first year following an ACS event. Early introduction of a PCSK9 inhibitor even before hospital discharge is highly supported by current cardiology literature to secure plaque stabilization. To summarize, mastering acute coronary syndrome requires a systemic approach. You must differentiate unstable angina, non-STEMI, and STEMI using ECG and troponins. You must implement immediate monotherapies while respecting morphine and nitroglycerin contraindications. Once stabilized, you must navigate the treatment fork. STEMI demands immediate emergency reperfusion via primary PCI within 90 minutes or fibrinolytics within 30 minutes, while non-STEMI and unstable angina demands risk stratification to determine the timing of an invasive strategy while avoiding fibrinolytics completely. You must expertly select antiplatelets and anticoagulants individualized DAPT durations using the DAPT score, protect complex atrial fibrillation patients with early double therapy over triple therapy, and finally, secure the patient's future with aggressive secondary prevention, pushing lipid targets down below 55 mg per deciliter. Thank you for joining this pharmacotherapy masterclass. Don't forget to like, subscribe, and share this video with your fellow clinicians. Keep optimizing therapy, and I will see you in the next clinical breakdown.